pocket talks anyways. So we'll get started. This is really an overview of dementia in general. So demystifying dementia. Um, we'll just focus on the most common kinds, and then we'll break those down into different talks themselves throughout the rest of the course. But so the goal today will be to first define neurodegenerative diseases. This is what causes dementia. And what is the difference between Alzheimer's disease and dementia? That's the most common question I get in the clinic, and it makes sense. Part of the reason is because we're kind of redefining the Alzheimer's disease timeline. Um, and then what are the most common causes of dementia? There we go. We got the video going. Um, And then when might a referral to a specialty clinic be reasonable to do? So when we define neurodegenerative diseases, we're basically talking about things that in general don't have a clear onset. It's sort of insidious. Oftentimes it's in retrospect. We're like, oh yeah, there might have been some things going on even up to 2 years ago, right? But it's not like a night and day difference like a stroke is. However, I ask about unmasking events often when I'm sort of trying to get a timeline down. And oftentimes there is this either really emotional event, maybe it was a move, maybe it was a death in the family, a major illness, a surgery, a TBI that sort of unmasked what was probably going on for a while. And then the other key feature of these diseases is that they're progressive, right? Which again differentiates from things like a stroke or other neurologic conditions. And this is due to progressive loss of synapses and neurons. And so it can look like this picture over here. This is someone that we had 6 different scans on throughout the research time. And you can see that over time, the brain undergoes loss of volume and overall hippocampal structure and overall cortical volume loss. So, the reason why, is still not entirely understood, but the general consensus is that in all of these diseases, we find misfolded proteins within the brain cells, amyloid and tau being the ones that are commonly seen in Alzheimer's, and alpha-synuclein being the one that are seen in Lewy body disease, and TDP-43 being the one seen in half of frontotemporal diseases. And the thought with these proteins is these are all very essential functional parts of a cell. And so we're getting a loss of the normal functioning protein when they start to clump up into plaques and tangles. But there's also probably some amount of gain of function toxicity as well, especially within the cell. So you guys are going to get these types of consults. We've already gotten a couple. You know, so in the future, right, this will be more common, but a 65-year-old patient might go and get a Quest Diagnostics or some other diagnostic blood test that says they have an abnormal amyloid test. And let's say, for example, that this is actually really a good test and it's indicative of amyloid plaques in the brain. They might have a family history of Alzheimer's disease. She's not aware of any cognitive difficulties, but now she's concerned with this result. Do I have Alzheimer's disease? And that's actually a major point of contention within the field. So I think most of us still suggest you need a clinical you need clinical symptoms to have a diagnosis of Alzheimer's disease. But that timeline, that understanding of what's happening in the brain for many years prior to clear symptoms, is where this biological definition and diagnosis comes from. And there are obviously other diseases within medicine that we have biomarkers that we call something, diabetes before someone has end-stage, neuropathy, nerve damage, or kidney dysfunction, right? So these things are, and this is obviously what cancer detection is striving for, right? Trying to find biomarkers that can obviously find these diseases prior to symptoms. And so this is going to change over time as we understand this better. But for right now, this clinical and biologic diagnosis is the most appropriate. But let's say we have the best blood test in the world. It's still not going to make a diagnosis for you, right? The detailed history, especially since we're saying that you need symptoms. So, getting that detailed history of how long has something been going on, what's the pattern of changes, these are still the most important part of the puzzle when you're making a diagnosis. Getting a good physical exam, having a good cognitive test, so mental status exam is important. Um, the one of the really big things that I worry about with these kind of easy button blood tests is that people might not do the other things that need to be done as far as ruling out the other potential contributing factors. If we're missing sleep apnea because somebody has a positive amyloid blood test, that's a really big deal. So you need to be still doing what are those other contributing factors? And we still need to be doing brain scans to make sure that this patient doesn't have, a tumor or some other structural change that helps explain things. And so the moral of all that, right, is brain diseases are complex puzzles. A blood test isn't going to be the one silver bullet for every diagnosis, but it can be an important piece of that puzzle, right? And that's where trying to put that together to where it kind of all makes sense is really important. So that's sort of, definition of neurodegenerative diseases. We've talked a little bit about Alzheimer's so far. Let's backtrack a little bit of just what even is dementia, right? So um, our definition is essentially you have to have, it's generally two cognitive domains that are impaired. So memory being the most predominant one, but maybe language or visual spatial or processing speed. And then this is enough to interfere with everyday function. And this term dementia is really just an umbrella term, right? It is a syndrome overall, but it doesn't tell us what the etiology or the cause of the dementia is. Those are where we get more fine-tuned diagnoses down below the umbrella. This is just another way to think about it. I think this is a nice visual for most people. So when we're talking about dementia, right, we're talking about, okay, there are clear memory concerns going on. Family might notice it more than patients. But there's also objective cognitive testing abnormalities, again, generally in two cognitive domains, and those activities of daily living are impaired. So here's a couple different ways to think about it. So just trying to differentiate between at least the top four. So Alzheimer's disease by far and away is the most common cause of dementia. We're usually talking about memory, especially short-term memory impairment, and we can see certain things on an FDG PET scan or an MRI scan. Whereas vascular disease, there's often this history of strokes or on imaging, some pretty severe amount of white matter disease seen. And whereas Lewy body disease, we have sort of you need 2 out of 4 of the core clinical features, which will have a pocket talk in and of itself on Lewy body disease. And then frontotemporal disease, there's usually a lot of frontal lobe damage happening, which if it's on the right side of the brain often involves personality and behavior changes and a lot of changes within someone's social decorum. Whereas if you have more of a language variant, that's usually the left side of the brain. And so how common are all these, right? So Alzheimer's disease, right? If you flipped a coin, right, you'd be right more often than not if you were calling things Alzheimer's disease. And this is variable depending on which study you look at. Some people say somewhere between 60 to 70% of dementia cause is Alzheimer's disease. If you lump Lewy body, Lewy body dementias, which we'll learn about in that talk, really lump together dementia with Lewy bodies and Parkinson's disease dementia. And so you lump those together, this is the second most common cause. And then vascular dementia is the third, with frontotemporal dementia being the fourth. And it's nice when it's broken down into these, simple categories. But in reality, you can have Alzheimer's disease and vascular disease. We can usually figure out which one's the primary pathology driving the bus, but the reality is there's a lot of patients. It's more common than not to have more than one thing contributing to cognitive changes. So just to summarize some of that, what's the difference between Alzheimer's disease and dementia? Again, dementia is the umbrella term. It really just indicates what are the severity of the symptoms going on. And then knowing that there's multiple etiologies with Alzheimer's disease being the most common one, But Alzheimer's disease really is a neuropathologic diagnosis. It is the evidence of amyloid and tau changes within the brain. And so now that we have biomarkers, we can measure it in the spinal fluid, we can do PET scans, we can now do blood tests that can help aid a diagnosis without having to go to brain tissue. Um, but the nature of these diseases being progressive, right? The more severe pathology that we find in the brain, especially with the tau protein, where is it in the brain and how dense is it, is more likely, more later stages of dementia. Um, with cognitive reserve being one of those things that can offset some of that pathology. So you can't always look at someone's brain and say, oh, yep, that's got to be severe dementia or not, right? But for most people, it's pretty linear there. Here's just a way to think about it from a timeline standpoint. So most of the time when we're diagnosing folks, we're in this red box. So that's at the dementia stage of these diseases, especially Alzheimer's disease. The purple line is basically what indicates that for you, where this is our cognitive measures and our activities of daily living. So more dysfunction going up here. The changes we see on an MRI or an FDG PET scan are usually around when we're seeing changes in cognition. There's all sorts of stuff happening well before that, years before. So there's mild cognitive impairment, which we talked about in previous talks. And then there's this sort of pre-symptomatic at risk stage. And so we can actually measure these things over time when we follow people for even decades in some research studies. So here's like an amyloid PET scan, which is, I'll tell you, is normal. Here's one where there's a little bit more amyloid, but it's still like right below our threshold. It's kind of like in the gray zone. And here's where, so somebody's kind of going up, and now we're in a clear amyloid positive phase. This individual would be at higher risk, right, of developing symptoms. At this point, the tau PET scan is generally pretty normal. So that's what this one is indicating here. And the MRI usually looks pretty normal at this stage as well. All we really have is changes in amyloid, and those changes in the blood can happen even before it's seen in the PET scan. And then we have a patient that's got a lot of amyloid in the brain. This is around when we see a lot of tau changes in the brain, which are tau is what drives the symptoms. This is where we start to see brain shrinkage as well. And then we have significant amyloid plaque pathology, significant tau pathology, and we have a lot of what we call neurodegeneration on the MRI scan. And then we have more later stages, which MRI is very abnormal. So right now, as Dr. Burns talked about in the last talk, the current monoclonal antibody approval is more for this stage. When we have clear amyloid in the brain, ideally we have less tau in the brain when we're giving this, but it's approved for this very mild dementia, mild cognitive impairment stage. We're actively testing this in folks that are amyloid positive well before these other biomarkers are abnormal. So this is a current trial that we have going on right now. So the better question, the better question for that individual, right, is really, am I at risk for Alzheimer's disease, especially if we're thinking of Alzheimer's disease as something that requires symptoms. And so, if somebody's got a very clear amyloid positive test, they are at risk of future tau positivity, right? And if you start to develop tau positivity, you're at risk for developing cognitive changes, right? And so another way to think about this is amyloid positivity is really more of kind of like that pre-diabetes stage. It's something that we really need to be watching for, right? But we don't currently have any treatments for. We're testing it on the research side. If someone has both amyloid and tau abnormalities, I mean, that technically is Alzheimer's disease, right? They've got those changes happening in the brain. So that's more or less what we would refer to as diabetes, but maybe it's like to the point where there's no clinical symptoms, or it's at least right at that border of preclinical stage. Once you start to get damage, so the neurodegeneration that we see on the MRI, that's kind of like uncontrolled diabetes, where you are basically at high risk of developing cognitive impairment and later dementia as this process occurs. So let's do a quick clinical puzzle. This is a 72-year-old that presents with some cognitive changes. They all started about 4 years ago. This is one of those emotional, right, events. Husband passed away. And that's when families started to at least notice more difficulties with words in conversation, and very reasonably kind of presumed this was a grief period, right? There was a lot of stress going on at that time. But really, and so the things were kind of mild over about 3 years, but then over the last past year, there's been significant difficulty getting words out in conversation. She's losing her train of thought easily, struggling with multi-step commands, and having significant anxiety. There's no really major concerns with short-term memory here, but she is having some difficulties with daily tasks. We're starting to paint a picture of there seems to be some early dementia going on, but what's causing it? As we kind of talked about in the last talk, it depends on what, you want to tailor your questions a little bit to what might be most relevant to what's going on. If you just ask her about repeating herself or missing appointments or medications, you might say, well, this is not Alzheimer's disease, or this is not dementia because they don't have a memory problem, which that would be inaccurate. She's having a lot of language difficulties, right? So we'd want to be asking questions about language. You might be asking questions about executive function too, because she's having troubles with some of those types of tasks as well. So her PCP did a good initial workup. We basically want to rule out those reversible things, especially B12 deficiency and other lab abnormalities. No real medications that are contributing, so she's not on any of these cognitive offending medications. She did have a sleep study done. There was moderate sleep apnea, so recommend treating that to try to help the brain function and slow things down. Her hearing is within normal limits. Whenever someone's having aphasia, good to check that as well. On cognitive testing, so a good cognitive screening tool, like we've been indicating in prior talks, was used. So this is a Montreal Cognitive Assessment. So she scores abnormally at 19 out of 30. And where does she really struggle, right? She struggles with repeating these complex sentences, so she cannot do that part of the MoCA. And then a little bit of difficulties with visual spatial and less with memory. So an MRI scan is ordered. That's an important piece of that puzzle. And so the purpose of these writers is to help rule out a structural problem. What if she had a large stroke within the left hemisphere of her brain that we just never knew about, or if she had a tumor growing in that region, a slow growing one? So there are things out there that can really help us, like AI, almost quantitative MRI programs, but most institutions don't use these, and most radiologists don't use them. So you're going to find that most reads are pretty generalized when you get them back. So like this individual, this was the read: generalized atrophy, mild white matter hyperintensities, which really just indicates some mild vascular disease. So I always say if you're going to refer a patient to us, so we have to look at the actual imaging. We cannot just go off a radiology read. So when we request these, right, and then I look at the MRI myself, right, I'm sort of looking for certain things, and there are very subtle differences, but these are very clear differences when you kind of drill down in it. If this is a slice of the brain where this is the front and the back, and this is the left side and the right, I think you can appreciate that on this right side, it's just more full in this temporal lobe than it is over here. There's more spinal fluid accumulating kind of around the temporal lobe, which is indicative of little shrinkage in this left temporal lobe. And I will say it's still pretty mild. You see this too in the parietal lobe, where there's just a little bit more spinal fluid up in the circle that I circled here. So to me, I'm thinking, okay, there's a little bit more left-sided atrophy. It's very mild. It might not be enough for me to be confident in the diagnosis, but it does warrant further workup because it's not quite normal either. And so like in this scenario, I've got a history of somebody with a progressive language problem or an aphasia, no real exam findings to think of stroke or other changes causing it. And then the MRI basically confirms that as well. On cognitive testing, it's more of this less of a memory predominant issue, more of a language issue. But we could say maybe the MRI is more of a non-diagnostic test here. So does this individual warrant further workup and a potential referral to us? I mean, this is kind of an atypical situation, so it makes sense to consider that. And so just a couple background things about that, right? So last month we got over 250 referrals, and we can realistically see about 80 of those folks. So we have to really fine tune and basically prioritize certain cases. this would be a very reasonable case because we, one, documented that they have clear abnormal cognition, right? And that's an important piece. Um, but the diagnosis is still uncertain. And those reversible things were looked into, which is an important part as well. We can't see patients with kind of family history or subjective concerns. We just don't have the capacity. Um, and then research referrals have kind of their own pathway. So that's important too. So this individual did get some detailed cognitive testing and essentially just confirmed our suspicion that the prominent deficits were in language and executive dysfunction. Because there is that multi-domain impairment and there's a decline in daily functioning tasks, this is consistent with mild dementia. It's sort of in this non-amnestic pattern though, and with that pattern being more of the dominant hemisphere, the language piece involved. Technically, this could still be due to Alzheimer's disease or frontotemporal disease. Both of those can cause aphasia syndromes. Um, so so we're thinking language is kind of where I'm focusing in at. We can do a little bit more advanced testing in these scenarios, especially when we're kind of trying to differentiate between Alzheimer's disease or frontotemporal disease. And so to do that, we use something called a PET scan, which really just tells us how the brain is working. Sometimes we'll use these in cases where we cannot get an MRI, say they have some sort of contraindication that can be very useful, or when the MRI is non-diagnostic. Another thing to point out about these neurodegenerative diseases, so they basically are brain network failure problems. Certain brain networks are really struggling, and we see these patterns and changes on these PET scans. The Center of Medicare and Medicaid Services, really since 2005, has had this approval for FTD versus AD. And so since we have these language problems, it makes a lot of sense. Generally, these should probably be something ordered by a specialist, from what I find in the wild of when these things are ordered. Sometimes the reads are not highly accurate. So this is what this individual's PET scan looked like. So here, gray is normal, and this is different viewpoints of the brain. This is the right side of the brain, the left side of the brain. And the more colorful something is, the more abnormal. And so we're seeing a lot of red here on the left side, and this sort of almost like a Nike swoosh, right? This sort of pattern like we see here. This is basically overlapping with the language network, and is why she's having so many difficulties with language symptoms. And when this back part of the brain, much more than the front, is involved, then that's highly consistent with what we see in Alzheimer's disease. In most individuals, we don't necessarily need to go in the next step of spinal fluid biomarkers, but say you had a really young patient, or you had you needed more confirmation either from you yourself or the family, you could pursue spinal fluid biomarkers, and that's where we would see changes both within the phosphorylated tau and the amyloid beta 42, and basically where like this individual landed in sort of a clear Alzheimer's disease box. And so this is logopenic primary progressive aphasia. We'll have our own talk on this later. So, but it's secondary to Alzheimer's disease, right? All right, now a more straightforward case, one that really is over half of the cases of dementia, right? This is somebody that's a little bit older, right? 76 years old. They've had 4 years of progressive memory loss. They've been repeating questions, missing appointments. They're living at home with husband and maintaining most ADLs, but struggling with some of the, pain bills and missing medications, some navigational difficulties. On a good cognitive screening tool, they scored an abnormal range, 18 out of 30. They're missing a lot of their points on that delayed recall portion. So it seems more of a short-term memory issue. Really no Parkinsonism or other findings on their exam. And this is their MRI scan, where we're seeing a lot of shrinkage within the memory structures. This is labeled yellow for you, this hippocampus. And here's the top of the head here. And so the right hippocampus, left hippocampus, we see a ton of atrophy there, and it basically fits with this bottom left picture, and this is why they're having the short-term memory difficulties. And so, like, does this patient need to be referred to a specialty memory clinic? No, not necessarily, right? We have all these pieces of information that really match up. The diagnosis is basically, Alzheimer's disease related to the clinical syndrome. the MRI scan, the cognitive testing. So this patient doesn't need a PET scan, an FDG PET scan. They don't necessarily need biomarkers at this point either. This might be a really good research referral. So this is this type of patient that we're looking for an Alzheimer's research study. But you're also going to want to get them plugged in with social resources and with disease education and things like that. So to summarize a few things here, the future tools of dementia diagnosis are going to rapidly change. They've already been rapidly changing. We're going to get AI that's going to help recognize these different patterns, these network level changes, and that's going to be really beneficial. We already have spinal fluid markers, but these blood-based markers are going to really expand access and ease of use, and that's really going to be a key change in what we're doing. We regularly use skin biopsies for Parkinson's and Lewy body disease confirmation. We've got more affordable genetic testing, which can be helpful. And then eventually, so we can order amyloid PET scans now, but we'll also be able to order tau PET scans in the future as well. And this last slide really just kind of highlights that Alzheimer's disease really can present in a lot of different ways, and these different tools that we can use. Here's a glucose PET scan versus a tau PET scan. Basically, where the tau is depositing is where the changes are and the symptoms are. And so these are going to really help us understand these diseases in a lot more detail as we use them more. All right. I'll go ahead and stop there. We'll see if there's any questions.